Dr. Liu, please.
Thank you. Uh, Good morning, everyone. I'm Dr. Liu Yang from Kaohsiung Chang Memorial Hospital. Today I would like to sorry. Today I would like to talk about the localized prostate cancer treatment choice, and I will focus on the ablation therapy, which were mainly HIFU. And we all know the pros of HIFU include minimal invasiveness, and we can perform focal HIFU or repeated HIFU. But there is a lack of comparisons with standard treatment and the need for the longer oncological outcome. Previously, we have published two papers comparing HIFU with other three treatment of choice for localized prostate cancer, and the conclusion showed that whole gland HIFU for localized prostate cancer showed non-inferior oncological outcome with radical prostatectomy and better urinary function improvement and more possible sexual function preservation than radical prostatectomy, brachytherapy, and cryotherapy. Moreover, there are three studies with long-term whole gland HIFU result, and the patient number sum up to about 2,000 patients, and the median follow-up was 5.3 to 8.1 years. The oncological outcome showed a 5-year biochemical recurrence-free survival about 80%, 10-year about 60%, and salvage treatment-free survival 10-year about 70%, metastatic-free survival about 10 years about 90%, cancer-specific survival about 100%, overall survival is about 80 to 86%. The functional outcome, the incontinence rate is about is less than 5%, and the de novo erectile dysfunction is about 50 to 60%. But we think the future of HIFU may be focused on the focal therapy. There is a systematic review published in the Journal of Urology in 2017. There are 7 studies with primary treatment setting for focal HIFU, and median follow-up from 6 months to 10 years. The patient is low to intermediate risk and unilateral lobe disease. The oncological outcome show that salvage treatment-free rate about 90%, metastatic-free rate about 93 to 100%, and the cancer-specific and the overall survival is excellent. The functional outcome show the urinary incontinence rate is less than 8%, and the de novo erectile dysfunction rate is 5 to 48%. So the results showed promising. And there are 2 studies about focal HIFU to radical prostatectomy (IRP). This is the first study which published in the Journal of Endourology 2017. It's a retrospective study focused on the T2A to T2B, PSA less than 15, and prostate volume less than 40 cc. There are totally 110 patients with IRP and focal HIFU. And the IRP patients all undergo the bilateral nerve sparing IRP. Median follow-up was 3 years. The oncological outcome showed no significant difference in the need of salvage treatment, all-cause, or cancer-specific mortality. And the complication and the functional outcome show HIFU shows shorter hospital stay, better and faster recovery of continence, and the low risk of de novo erectile dysfunction. Even IRP patients all undergo nerve sparing. Another studies which is published last year in the Journal of Urology there is a prospective study with propensity score match, and the median follow-up is about 38 to 47 months. Also, it's patients disease less than T2B, Gleason score less than 3.4, and the PSA less than 15. Total about 1,500 patients, and the IRP group finally included 472 patients, and all patients have nerve sparing surgery, and the partial gland ablation, which include HIFU and the cryo, is about 236 patients. The oncology outcome showed no difference in biochemical recurrence-free, but in the partial gland ablation, there are about 30% biopsy positive failure. In the treated lobe or bilateral lobe, it's about 25% of patients found the biochemical proof failure. And the salvage treatment rate, partial gland showed significantly higher rate for the salvage treatment, about 21%. Metastatic mortality showed no difference. In the functional outcome, the partial gland ablation showed less incontinence rate and less de novo erectile dysfunction rate. About nearly 90% of patients' sexual function was preserved, and the higher IIF-5 score. So here's the conclusion. Whole gland HIFU have showed long-term and comparable outcomes for efficacy and safety, according to the previous review. Focal HIFU in the selection patient, low to intermediate risk unilateral lobe disease also review is very even compared with IRP, but close follow-up and more possible salvage treatments may be needed. And the HIFU may be the bridge between the active surveillance and the radical prostatectomy for localized prostate cancer. Thank you.
Let's open for discussion. Just one. Okay. Thank you for Dr. Young's inspiring lecture for the HIFU for focal therapy. Alternative choice. Thank you. Let's move to the second speaker. Let's welcome Anthony Wu, Professor Wu. Professor Wu is from Hong Kong Chinese University, and let's welcome Professor Wu.
Thank you. So today the topic is the management of the localized prostate cancer and the controversy related to that. So I would like to shift the focus a little bit to not from the surgeon side or from the doctor side, and go to the patient's perspective to see how they will choose the treatment for them for their disease. In fact, from a study, it showed that for patients when they have prostate cancer, what are the most concerning factors that are affecting their choice of treatment? In fact, certainly as they are having a cancer, therefore they would expect they should have a disease being controlled and being cured, and there's no biochemical recurrence, and also they were also expecting there's no major complication related to the treatment. And from there's not many prospective study on this aspect, but the post-test study have given us some of the insight about the treatment outcome. And in this 10-year outcome follow-up of the post-test study from the UK group, and I see that no matter what you treat the patient in for this localized prostate cancer, whether you're by surgery, radiotherapy, or active surveillance, by 10 years time, the prostate cancer specific survival is almost 100%, and there's no difference between the three groups. And for the disease progression, certainly we will expect for the active surveillance group there will be some progression, but otherwise for operation or radiotherapy, that's the disease progression is the same. Therefore, that means whatever treatment the patient receives, probably they will have similar outcome by 10 years time. So besides survival, any other thing that the patient will concern or that we may need to consider during the choice of treatment? And going back to this figure, we can see that besides the biochemical recurrence and no major complication, other concern for the patient will be some of the functional outcome, as we discussed before, like incontinence and also erectile function. And at the end, in fact, cause is the one of the least concern for the patient, because I think they will expect a better disease control or outcome rather than the cause. Oh, again, we look back to the post-test study and can see that when you from the patient, for the urinary symptom, it will be expected that for those patients after surgery, they will have more incontinence compared to the other two groups, and also the number of patients that need to using more than 1 pad per day will be significantly higher for the patient with surgery, in particular in the first year after surgery. And at the end, despite in UK you expect that they are already in Caucasian population, they are quite experienced in doing surgery, still around 20% of patients will need to using more than 1 pad per day after 6 years of follow-up. Other function like sexual function, and it will expect that after both surgery or radiotherapy, the sexual function will be significantly dropped compared to the active surveillance group. However, at the end of 6 years, you can see that the three groups actually are merging together. Therefore, at the end, maybe sexual function is not that make great difference between the different groups. Another function that may be affected by the treatment will be bowel function, because as expected, radiotherapy may affecting the bowel, and you can see that from this data, after radiotherapy, there's a sudden drop in the bowel function, and also patient may have experienced some bloody stool at the end of the treatment, and this bloody stool is actually quite persistent. Even after 6 years, the patient may still have around 10% of patients will have this bloody stool in the patient. So, in fact, because of the information on the patient report outcome in Asian or in Chinese population is not that many. Therefore, our group tried to do a small project by some of our medical students to see how to fill the gap on this knowledge absent in the situation. And therefore, we have do a small study on doing a patient report outcome in our patient. We selected a group of patients diagnosed to have cancer in 2010 to 2011, that's around 6 to 7 years ago. And then by the end of 2016, we have sent them a questionnaire by mail to ask them to fill in the questionnaire, the EPICS questionnaire, and then send it back to us. And also we try to review the data from the medical record to see what had happened in the past 5 to 7 years during that follow-up. We choose this particular 5 to 7 years, it basically is almost similar to the post-test study, and also by that time most of the acute complications related to treatment should be settled, and then we can assess a more stable patient at a more stable condition. And altogether, there's around 60 patients in the radiotherapy group and 30 patients in the prostatectomy group. And you can expect that the age is slightly older in the radiotherapy group, and also performance status was a little bit lower in the radiotherapy group, because most of the time it's the older one or less fit patient choose radiotherapy. And similar to the post-test study, you can see that actually for the urinary function, you will expect that by 5 to 6 years later, still quite significantly more patients will have urinary incontinence compared to in the surgical group compared to the radiotherapy group. However, for the bothersome of the symptom, actually both groups are almost similar. Therefore, despite they have more urinary incontinence, however, from the patient's perspective, it seems that the border of the urinary symptom is not that significant different between the two groups. And for the bowel function, actually it's the same for the three groups. The patient didn't experience any significant difference in the bowel function despite they are receiving radiotherapy. For the sexual function, actually both groups are quite low. Maybe in the Asian population, particularly in Hong Kong, their sexual problem is most of patients when they are already 60, 70, the sexual function already not that well. Therefore, both groups have poor sexual function. However, as expected, they are also not that bothered by the sexual function. Therefore, there may be something that we are less concerned by the patient. However, besides the patient report outcome, we also look into some of the data. We can see that over the 5 to 6 years time, while those patients with prostatectomy have more incontinence compared to the radiotherapy. They have, well, for the RT group, they also have more other symptoms, other low interest symptoms compared to the prostatectomy group, maybe more irritating symptoms. Also, more unplanned admission was observed in the radiotherapy, although it's not statistically significant, but most of them is due to some of the rectal bleeding or hematuria or acute retention of urine. Therefore, you will expect that for those patients after surgery, they will seldom come back to the hospital, while for the RT1, sometimes they may have some severe symptoms that causing them to go back to the hospital. And lastly, knowing that they have those treatment have some complications, so how to choose the best treatment for our patient, and for discussing in some of the previous previous speaker. So older patient, obese patient, or those patients already have some pre-op avoiding symptoms, they may probably have more chance of having post-op incontinence. Therefore, this may be those of the group of patients that may lead to think about whether they will go for surgery or they may consider other treatment. However, on the other hand, some patients may have some pre-existing disease that may not suitable for RT because they may have other complications related to RT, like previous irradiation, or patients with inflammatory bowel disease, or those patients that have a significant cardiovascular or metabolic problem, and because of the use of ADT related to the RT, they may need to consider whether they will go for RT or not. And these are some of the some special histology that more aggressive may not be respond to RT, they may need to consider for surgery. So, and therefore, in summary, for those patients with a localized prostate cancer, besides consider the oncological outcome, functional outcome, and also the potential adverse event related to treatment is also important thing that we need to consider for our patient. Therefore, a careful counseling to the patient, and also providing the patient with necessary information will help them to choose the best treatment for themselves. And that ends my presentation. Thank you.
Let's welcome the third speaker. It's Professor Shinichi Sakamoto.
As well, thank you very much for giving me opportunity to present, and I'd like to thank both Dr. Chang and Dr. TOA for inviting me to present. And I kind of switched the slide this morning, I'm sorry, because oligomets is not localized cancer anyway. So I'd like to talk about the risk of classification of localized cancer. This is Chiba-Gung. Do you remember this is limited in the structure of Chiba prefecture. And also next year JUA we are hosting their annual meeting. So I heard many people actually visiting from Taiwan or maybe Korea as well. So I'd like to welcome you to join the JUA meeting. So when you think about treatment option local prostate cancer, there is so many options. However, many are actually depend on the guideline and also patient preference. So I would like to think about risk evaluation, and those clinical questions you will be considered local cancer outside the guidelines. So what kind of feature we have in Japanese or Asian patient? The first is low risk patient, active surveillance criteria in Japan, US, and TB rating 0.5 cc and incident cancer, and high risk patient tumor volume, and evaluation based on the MRI and ISAP. So first one is in case of low risk patient, we previously compared I think there is one data from South Korea as well, so basically similar data anyway. So if you compare the P patient population with much active surveillance and compare the incident cancer is 0.5 cc less than, and organ confined Gleason 6. Matching rate for the incident cancer is very low compared to US. So this is very typical. I think it's same in South Korea and Japan anyway. So what is the characteristic of 0.5 cc prostate cancer? We further study the patient data with 71 patients with less than 0.5 cc cancer, and there's so many high Gleason score, even 0.2 or less than 0.2, so which indicates tumor volume does not necessarily indicate in the low Gleason score. I'm sorry, this is this is Gleason 3. This is kind of mistake. Anyway, this is Gleason 3 plus 3 is 3.4 and with 4 plus 3. I'm sorry, this is kind of mistaken. So US counterpart, this is around 80% as average, so which much higher Gleason score in pathological feature in Japanese patient background. And also we look at the introductory carcinoma, which is recently being recognized as very poor prognosis. And out of 4, it's not so high anyway, but out of 71 patients, there is 4 patients has their introductory carcinoma. And all the patient, interestingly, all the patient has a territory 5 component at least. So if there is 3.4 or 4.3, but if there is small amount greater than 5, which may indicate the presence of introductory carcinoma, and those patients should be poor prognosis. And if you compare the patient characteristics of introductory carcinoma, they have low testosterone, little bit higher tumor volume, and higher pH density. Although this is not significant. So in case of high-risk patient, we kind of study the large amount of patient and study the risk of biochemical recurrence in like-positive patient. And tumor volume 2.5 seems to be the very high indication of the biochemical recurrence or poor prognosis. And as you can see in this figure, 2.5 seems to have a poor prognosis. And if you compare the hazard ratio in the more than 2.5 become 4.4 risk, and if greater than 5 is like 6. So 2.5 seems to be the kind of one cutoff to predict prognosis. But this data is based on the pathological outcome, so we have to detect those tumor burden before the operation. So should be the MRI to assess the volume anyway. So as many people present, PIRATS version 2 is recent scoring system to evaluate the tumor by MRI, but recently biparametric MRI with no DCE also recommended. So we studied the PIRATS with no DCE with critical biparametric PIRATS, and tumor volume seemed to be positive. In case PIRATS positive seemed to be 2.5. So based on the PIRATS, maybe we can predict the tumor volume 2.5. And those, as you can see in this figure, those patients have significantly poor prognosis. And if you show the predictive factor, ISAP and PIRATS seem to be independent factors. So if you combine these two together, you can significantly differentiate the prognosis population. So summary, difference in active surveillance criteria, there is more single cancer in Asian patients, especially in Japanese. And 0.5 cc, you have to sometimes be careful about the presence of introductory carcinoma. In case of high risk, tumor volume seems to be one of the indicators, and the PIRATS in ISAP may be useful in predicting outcomes. Thank you very much.